Thank you for the opportunity to share with you my reluctant journey as I've been told, learning to be an advocate, and how I grew from a young physician in training, thinking I was going to work with my teachers and have a wonderful faculty and be able to improve internal medicine care, so adult care. My story is an experience of many pioneers in low and middle income countries who find themselves in a system that is compromised in the number of resources that can actually support specialized care. Our health systems are there to cater for most of the patients that are engaging with our health facility. I've intentionally put that picture because it tells you that my healthcare system prioritizes primary care. The reason is I'm one of the rare species in the system that is actually providing care to our patients. I stay in the ivory towers of referral hospitals. And sometimes we actually give our services to district hospitals. But we're always overwhelmed. We're providing services to a population of 18 million. And like in emergency medicine, there are currently 3 of us to do that. Provide advanced and definitive emergency care to that population. Now, advanced and emergency care services require gadgets, infusion pumps, a rare commodity even in my central hospital. So how am I going to do that? So my story starts as a naive specialist who's excited, having come from South Africa, finished my hybrid internal medicine training, and then asked to help support the improvement of acute care for adult patients. I'm part of an interdisciplinary team, but they left out a lot of detail. I may not have signed up for this job. What was the motivation? Wellcome Trust and an Advocate family had provided some resources that enabled our hospital to create more space, a lovely resuscitation unit, and we're now able to provide oxygen to those patients who are coming with respiratory failure. Well, exciting, but daunting at the same time. But I thought, well, it's all about specialized care, so why shouldn't I be excited about this? So, like a usual specialist, data. And I've been trained in a system where we're encouraged to provide evidence for why we exist in a system that is focused on primary care. But we're also encouraged to be flexible so that we are not extinct in a system that cannot actually sustain our expertise. So I decided to put my skills to use. We did an audit with my colleagues of, let's characterize the type of care that we're offering at the moment in our acute care system. Well, the surprise was we were a glorified primary care center because most of the patients that we were seeing in what we called a referral hospital were actually getting primary care services. So those are patients who were actually accessing specialized care at the academic hub of medical and nursing training in our country were only being able to access the many specialists in that hospital, only 13% required our services. The patient with respiratory failure, the patient with blunt abdominal trauma, was somehow getting to be stabilized and then get definitive and advanced emergency care services, and probably also some other specialized care, were only 4% of the people that were actually coming to our referral site. Why was that? We had 3,000 people engaging with our referral center every day. Probably that's why we talked about feelings, because the health-seeking behavior of our patients was that they were more prepared to come to this referral center rather than queue, as you can see in the photograph, at the primary health centers that were scattered within our district or city, and were able to cater for the large community that is growing in the urbanized areas. So why were they sitting in a queue to access primary care in a specialized or tertiary center? They're on discussing with the patients, because initially it was like, let's enforce the policy. You are supposed to access health emergency care services at primary care centers. That's where basic emergency care is available. So you coming here is compromising our ability as specialists to be able to give you the reason of why we are trained. Well, they said, well, have you been to the health center? They limit the time frame in which they provide services. The other problem is, before I even tell my story, once I say I've come for a cough, someone is already writing a prescription, and they don't touch me. They don't touch me. That's not the way a doctor provides care. And then I'm given a prescription for Panadol. Panadol or Amoxil, which is not available in that primary care facility, and then I'm asked to come to this referral center to access these drugs. Now, I definitely did not sign up to be sorting out a system. My idea was, let's create a center of excellence and let's practice specialized emergency care. But this was there. It was definitely clouding the way we would be able to set up this service. I was the only specialist when we started in that setting, and for 20 years, doctors had not been in the front door of the hospital. So everyone was timing the clock for when I'll put in the towel and probably go back to my medical wards. So, I'm not sure what happened. Probably amazing mentors helped me realize the skills of defining a problem do matter. They allow you to navigate the tunnel of minimal visibility. So they said, let's characterize the patient and then see where the problem is. And what we found out was those patients who were bypassing primary care came from the largest township in that city, 40%. The other aspect was the way we had actually localized our primary care centers. The vendor in the CBD area, the white-collared professional who can't afford the few private health facilities, and the mother who's stranded on a bus station but needs to look after themselves because they've developed diarrhea, didn't have a place where they would access primary care. So 11% were left unattended and needed to use our referral site. That made it easier for us to find the solution and collaboratively, as specialists, work with the primary care system that has a different jurisdiction and funding source is larger than we do, and say, let's work together and see how we can improve primary care. So what did we do? We got together as a Blantyre District Health System, academics, as well as those in public service. By the way, I am in public service. And say, let's lobby to the Central Ministry of Health and ask for deployment of more staff to this particular health center. The other thing is, let's optimize its capacity so that we can be able to offer district or community hospital services. And this was the right opportunity because we're also starting to develop family medicine specialization in our setup. And we viewed that the family medicine specialist was best positioned to start supporting the primary health care. We also encouraged ourselves to say we could open a primary care center. So actually a house was renovated with private funding, and we were able to create a health center. So, remember the feelings or perceptions that the patients had? We realized over time that we needed to contribute our expertise in improving the basic emergency care package in that setting. So, basic things which you may think is normal to understand is triaging, prioritizing care. We collaborated with other health professionals, pediatrics, ourselves in adult care, and started providing opportunities for health professionals to understand what triaging is all about. We also empowered knowledge, attitude, and practice to these health professionals so that they can be able to understand that actually you can do better and you can provide time-sensitive care to patients who are coming with emergency needs. Was it successful? I have facts. Over the past 7 years, we have seen a difference. Firstly, the patient is able to engage with a primary care center in our district. Before, absolutely everyone came to the central hospital, but now 47% are able to say, I will still have doubts and come to the referral center. As a referral site, we have noticed that we're actually being more useful. We're providing the extra help to those who are offering primary care by patients being referred to us, 53% when it used to be 4%. And you can see that our district health system has great figures now to lobby resources and say they're actually fulfilling the mission for existence. I better not forget why I exist. And I need excitement. I also need professional growth and development. So how are we able to do that? Now that we have a lower patient volume, reduced by 10 times, very astounding to me when I was looking at the data now, is that now we're able to focus as specialists in our emergency department and create a center of excellence where we will be able to indeed showcase to other central hospitals that we can do it. We can have an emergency department. We should have emergency care physicians. The other aspect is that we are also making sure this motivates the academic activities that we have. inspire the young physician who needs to specialize in emergency medicine. So why am I making this case? My flexibility and all other specialists in a system that sometimes thinks we are the Mercedes-Benz when we need Toyota Corolla in our system. We can have a Mercedes-Benz. By the way, a Mercedes-Benz, the A-Class, is it? And the modern one can exist in our system. But how will we do that? Me, as the expert, needs to understand, in my setting, I will be involved and engaged with basic emergency care. And I should be flexible to provide the appropriate care that will make an impact, a significant impact to the multitudes. And thereafter, I will be able to attract others to join me, and we should be able to reach the level of having emergency care departments as you have. Thank you.